and thank everyone around the world who has joined us this morning. My name is Bob Woollard. I'm the privilege of moderating today's discussion, and we will get into that in a moment. But I do want to thank everybody who has joined us this morning. This series of webinars is an important function of the Network Towards Unity for Health as it moves forward, and we all move forward. This year's meeting in Darwin, Australia in August, but also to develop this community of people that are interacting, that are taking us forward through some of the major issues that confront us as in the world, and ways in which we can advance, in this case, the influence of accreditation standards. I want to just briefly say I chaired the Accreditation Standards Committee for Canada, both for undergraduate and continuing professional development for many years, and also was on the executive of the LCME. And so have some background, and as I'll mention with the introductions, have had the privilege of knowing the four panelists whom I welcome to this discussion, and I hope that we will have a rich discussion. Let me welcome initially Alejandro Avelino, who is a fresh doc, and I've known Alejandro for several years. He chaired the student network organization and is in Bogota today. Björg Pálsdóttir is I've known for many years and have been delighted to work with. She has been a founder and a driving force in THEnet, which is the international organization many of you will be familiar with. If you're not, then please Google it and get to know it. That's an attempt to develop, among other things, how would we know we're getting more socially accountable? Good intentions are a dime a dozen, but how would we know if we are actually moving forward in that direction? And Björg has a great depth in that. John Wynn-Jones, I've been privileged to know as he heads up the rural WONCA division and has been incredibly active in terms of bringing the perspective of rural, which is often marginalized even by accreditation standards, moving forward. Titi is a thought leader and educational leader in Indonesia and indeed all of Southeast Asia, where she chaired the CERAME. And I had the privilege of working with her in the actual development of Indonesia's accreditation system. So those of us with countries that may be large but have small populations can only imagine the challenges of the thousands of islands and millions of people and their health that's represented and influenced by the accreditation system there. So I just wanted to give that picture of everyone that's on the panel so that we can see if we can collectively, by the end of the hour, become more than the sum of our parts, that with the help of the people who are online, they're used to the chat box or conversations, we will all come away better able to advance the cause of social justice and the role of health professions in advancing social justice and fairness around the world. To get started, I'd like to ask each of the panelists to take a few minutes then to introduce yourselves, your organizations, your work that's relative to accreditation, because all of you have such full lives and contributions. This would only be a part of it. But how does that, your sense of what you've done, what you're doing, and what you're interested in inform global health care? So we shall start with the youngest, and Alejandro, do you want to take it away?
Sure, well, thank you very much. Good morning, everybody. here in Colombia it's in the morning. If you're in the afternoon, well, good day. Well, as Bob said, yes, I was a student representative for my university, the Corpus University here in Colombia, for 3 years. During this time, I participated in the accreditation process in high quality of education for the undergraduate program of medicine, as well for the postgraduate studies of family medicine, and more recently for the university itself. As Bob said, I'm also the former president of SNO, the Student Network Organization, where I was member of the board of directors, and also I got actively involved in the task force of integrated medicine and public health. And now I'm the coordinator of the reviewing process of students' articles for the Education for Health journal. I'm currently working in the family and community health program, and also in the research area in the Nuestra Señora del Carmen Hospital here in Tabio. It's a town near Bogota. I'm also studying to become an epidemiologist and hopefully a public health worker in the future. With accreditation, we have been working as well in the hospital. We just began the accreditation process for the institution. So I will say I have been around accreditation standards around over 4 years.
Björg.
Hello, everyone. So my name is Björg Pálsdóttir, and I lead the Training for Health Equity Network, or the THEnet, which is a small but very dynamic nonprofit and a global community of practice of schools around the world that are committed to social accountability, and that have been doing that work for years. And we are also members of the network towards Unity for Health, but we're sort of a smaller subsection, if you will, that's really focusing on research, evaluation, and capacity building. And what the THEnet is, it was actually started as a research project looking at institutions that were trying to address the health workforce crisis. And we identified previously isolated innovators that were what we understood were actually sharing common strategies to address the needs in the communities that they were serving. And the first project we actually, when we brought these innovators together, what was agreed is that we needed to understand and find ways to measure and to see whether these schools were actually having the desired impact. So our first common project was to develop an evaluation framework looking at social accountability and looking at the impact that institutions can have on health in the communities that they serve, with a particular emphasis on the most underserved. And what we discovered is that even though these schools were working in very different systems, they actually shared some common strategies. And those are strategies that have now become associated with social accountability, which is they're community engaged, work very closely with communities. They select students based on criteria with the goal of increasing retention. They have very early exposure to the clinical environment, and what they do, they actually integrate social and social sciences, clinical sciences, and what they do is they actually train to a great extent. Some of them, up to 50% of the training takes place in either in community settings or primary care settings or at secondary hospitals, rather than the traditionally where much of the clinical training takes place in hospital settings. So what we have been doing, we're actually, last year we turned 10, and what we have been doing is, like Bob mentioned, we've been doing a lot of research to really try to understand what works how and in what context. And this is one of the reason I think what's slightly different from what the network does is that we've been trying to focus on institutions where there's institutional commitment to social accountability. There's amazing people working around the world doing incredible things in different kinds of departments, but we're trying to understand if there's a way to make sure that institutions remain committed to addressing needs beyond the change in leadership, because it has to be said, all these institutions were started by amazing, committed individuals. And what we're wanting to understand is how do we put in levers in place or institutional structures that make sure that the institution or the programs are committed to social accountability and addressing needs, no matter what happens. And again, this is one of the reasons where accreditation is an important part. It's that is sort of an outside lever direction. And we are very keen on making sure that accreditation standards are reflective of social accountability. They don't have to be called social accountability, but that they actually not only focus on sort of quote unquote international standards that are transferable, but that you also make sure that institutions align their programs to address their local needs. So you're not necessarily, not promoting migration, but that you're actually really trying to ensure the quality of the education, the relevance and equity in it. And we've been involved in various efforts sort of on global, mostly in advocacy at that around accreditation. And we're very happy to say that we were instrumental in making sure that the WHO Global Strategy for Human Resources for Health incorporated social accountability as a part of what countries should do. And the way they will track the success of their global strategy is through the National Health Workforce Accounts. And there are a couple of indicators in those accounts that suggest that schools or nations should actually incorporate social accountability standards. And I'll sort of leave it at that.
Thank you very much, Björg. That's a nice weaving of together of how accreditation systems, which are sometimes seen as simply audits by some central body, actually are integrated. John, you've been a real leader in advancing the particular issues around rural medicine. We'd love to hear your thoughts on how does accreditation fit into the fact that systematically rural folks have, as a population, lower life expectancy, etc. And that seems to be fairly universal. And I'd love to hear your thoughts on how accreditation might address some of those issues.
Thanks, Bob, and thanks for the kind words. I'm not really an academic, but I've worked as a family doctor in a rural area for nearly 40 years, and 35 years of those are full-time. I'm currently part-time lecturer in rural and global health at Kiel Medical School, but the main job is really the chair of the WONCA Working Party on Rural Practice. And now for those who don't know what WONCA is the World Organization of Family Doctors. I took over as chair 5 years ago, and I've been guided by a number of goals since then. First of all, gender and age equity. I wanted the organization to be actually kind of equitable. I wanted it to actually represent the rest of the world geographically and demographically. And I wanted to ensure that the voices of ordinary working doctors, rural working doctors, were acted about. There was a balance between academia and people working on the shop floor. And I think we've achieved that, and I'm really kind of proud of what we've done. As far as today is concerned, we've just got to ask ourselves, what are we aiming for? I mean, it's of course about achieving equity, but and all those disadvantaged people around the world, but it's about human rights, it's about ethics, it's about legality, representation, culture, beliefs, and much, much more. And I really keep on saying this, that 48% of the world's population is rural and isolated, yet only 38% of the world's nurses and only 24% of the world's doctors care for them. And according to an ILO report, 56% of the world's population do not have access to healthcare. Whereas that's the rural population, whereas only 22% of the urban population. And the scariest figure was that actually 83% of rural sub-Saharan Africans have no access to healthcare. Last year marked the 40th anniversary of the groundbreaking Alma Ata Declaration, which aimed to eliminate poverty, bring health to all, and promote primary care. And it's been really successful in the sense that it didn't achieve it by the year 2000, but it spurned the Millennium Development Goals, which have been really incredibly successful if you look at what they've achieved, and now the Sustainable Development Goals. WHO produced a new declaration in October in Astana in Kazakhstan, and I was involved, like many people, in looking at the draft for that declaration, and it didn't even mention rural. And yet, when we're going to achieve universal health coverage, rural will be the greatest challenge. So we produced our own declaration, which WHO Fair Play have put actually up on their website, so they do see some value in that. It's a rural version of Astana, and it's the 6 guiding rules are equity of healthcare, rural proofing, health system development, developing and educating a workforce fit for purpose, realigning research agenda and people and communities. And that's our manifesto for the future. So when it comes to training the workforce, we must ask ourselves what the workforce should look like and how it should work. Sadly, medical schools and other training institutions bandy the word excellent around everywhere, but excellent for what? And if we're going to achieve social accountability, it's going to be for that 58% of the world's rural people. We've just finished a body of work for the WHO on training pathways for health workers. That's all health workers, not only doctors. And it consisted of a literature review and a checklist, and we hope that's going to be published soon. So do look out for that. And what really was a great surprise, there's some fantastic things happening worldwide. And this was based on low and middle income countries. So it's not all bad news, there's a lot of great stuff. And I think what we need to do in WONCA and what you need to do in Network Towards Unity for Health is actually about promoting that. But there are disruptive influences, Bob, and also where healthcare is dominated by urban specialisms. And perhaps I could bring you to your attention the new Indian MBBS curriculum. And this is an example. It doesn't even mention family medicine. And you know, how are they going to provide healthcare for 60% of the vast rural population they have, really? So I'm going to stop there, Bob, because I know a lot of things will come up in the conversation. But just to remind people that we have our conference this year in Albuquerque in October. Everybody's welcomed. It's preceded by AAFP, American Academy of Family Practice Global Health Summit beforehand. So it's really a wonderful opportunity to immerse yourself in rural and global affairs. So if you want to learn more, go and have a look at our website. But thanks for the opportunity, Bob. Thank you.
Thank you very much, John, for weaving things in. One of my functions is as Associate Director of the Rural Coordinating Center here in British Columbia, which tries to address at the provincial level some of those powerful issues that you mentioned. And one of the realities is that very often it's the rural scale at which some of the most imaginative and, as you, to use your word, disruptive places where positive things are happening. So I think the connection, not only across nations, but between urban and rural, is an important place for us to flag as we think about because and as I turn to Titi, who has some particular experience that I think is relevant to this, accreditation systems can actually marginalize the opportunity for learners to work in rural areas. It can actually compromise the delivery of health services if we see them not as a springboard to innovation, but as some sort of a constraint on the way in which teaching and learning can happen. So that's worth thinking about. Titi, I had the pleasure of meeting in Indonesia, and we were working on a World Bank project on developing an accreditation system. And Titi, in addition to building on what's been discussed here, one of the other questions in the issue is, is the development of standards and accreditation in addressing the issue of the virtual explosion of private for-profit medical schools around the world. And I know that when we were working together, there was something like 70 new for-profit schools in Indonesia. And part of the challenge was how, in fact, does the quality of education get influenced by an accreditation system, and how does it deal with that? So this is a very rich discussion, and I look forward to your comments.
Okay, hello, Bob, other panelists and participants. First of all, thank you very much for inviting me to join this challenging virtual symposium. Secondly, I would like to introduce myself. I'm Titi. I'm currently working as an associate professor in medical education at the Faculty of Medicine, Gadjah Mada University. But currently, I'm seconded to the National Board of Education Standard under the Ministry of Education. Also, internationally, I have been involved a lot in the development of AUNQA, ASEAN University Network for Quality Assurance standard. Also, I'm involved in the WFME in reviewing the result of assessment or for recognitions of accreditation agencies. Accreditation is a complex issue. In my country, before 2014, we only have one single national accreditation agency who were doing accreditation for all programs and for all higher education institutions. My country, Indonesia, has around 250 million populations, and we have almost 24,000 programs, education programs, and also almost 5,000 higher education institutions. So it was really a daunting task for them to accredit all every 5 years. Therefore, around 2008, there was an urgent call from the Association of Indonesian Medical Schools to establish an independent accreditation agency just for a medical school. It is possible by our law, and then luckily there was a World Bank funded project where Bob was also involved in this. So the independent accreditation agency was set up by 7 professional associations and 7 education institutions associations in health. It is called Independent Accreditation Agency for Higher Education in Health. When we talk about accreditations, in fact, we talk about regulation. By our law, accreditation is compulsory because if study programs do not have accreditations, they are not allowed to graduate. They are not allowed to give a degree. So every programs, every education institutions have to be accredited. And also, because of this is compulsory, so at one time, accreditation has become like a formality, because a lot of institutions, they don't look at what it is the purpose of accreditations. They would rather just try to fulfill all the documents, all the requirements. To make it worse, the accreditation system or methodology is still like ticking the box. Do you have this document? Do you have that document? And that's it. So because of the youth task to do accreditations for our national accreditation agency, Therefore, the Indonesian Medical School Association asked the government to have a separate independent accreditation agencies. And we have this in 2015, and now this accreditation agency has been up and running. And until now, there are about 3,000 study programs have registered to be accredited by this new agency. And then for the standards, then we try to have our own standards. But because this new accreditation agency is still under the supervision of the National Accreditation Agency, so we cannot really have a freedom to modify our own standard. Standards competence for medical doctors and educational standards for medical professions are approved by Indonesian Medical Council, but they are formulated by the collaborations between Indonesian Association of Medical Schools and Indonesian College of Medicines. In addition to that, all other stakeholders are also involved, like the Ministry of Health, Ministry of Research, Technology, and Higher Education, Association of Teaching Hospital, National Health Insurance, Indonesian Colleges of Medical Specialists, etc. So we try to modify our standards, not to be exactly the same as the higher education standards. We include also details, list of diseases, list of health problems at individual and community level, as well as list of clinical skills. For list of disease, we categorize the abilities into 3 levels, namely level 1 is mastery of knowledge, related knowledge. Level 2, able to refer to the relevant specialist. Level 3, able to provide initial diagnosis and initial treatment before referring the patients to the relevant specialist. And level 4, to be able to diagnose and give treatment independently, including follow-up treatment. So we developed these categories together with the Indonesian College of Medicines. And also we have a list of clinical skills. It means what skills that are important for new medical graduates to master before they enter into the internship programs. Developing these standards are really a painstaking, because it involves a lot of people, 33 colleges of medical specialists. And also we try out or to test the standard in about 15 medical schools across the country. Eventually, these standards, the first one was approved in 2006, the second one was approved in 2012, and these standards really have transformed the medical curriculum. Following the enactment of this standard, all medical schools reform their curriculum into competence-based curriculums, and it really bring a lot of enthusiasm from many medical schools to improve their education system, and they were assisted by grant from the World as a stimulus, a startup to do innovations in their medical curriculum. So shortly speaking, almost every medical school, now we have 89 medical schools, they have tried to develop their curriculum as well as to develop their education system, infrastructure, etc., in line with the standard, because it is requirement in our country now that every medical school, they have to be accredited first before they are given permission to operate and to recruit students. Therefore, they try their best to fulfill the standards. However, as in many situations, sometimes the establishments of new medical schools are influenced by political considerations, like in a very remote province, although maybe the standards are not really in line with the requirements, but they are still given permission to operate because of, you know, the political demand, etc. In fact, by law in our country, all higher education institutions have to be non-profit. It's by law. They are not allowed to be profit-oriented. However, although they are officially they should be not for profit, but in fact they charge quite a large amount of money from the medical students, also from the parents. And up till now, we don't have instruments of how to control this. And to what extent the accreditation system have an impact on the healthcare in Indonesia? First, based on my observations to be involved in this project, and also after the projects ended, in fact, by having our own independent accreditation agencies and also by having our own standards, these standards can be leveraged for changes for medical schools. It drives them to change. It drives them to improve. However, this enthusiasm is not followed by the improvement of accreditation system. Our accreditation system is still using the old style, the old ways. That is the checklist, the ticking box for every parameter. What is the ratio? How many books do you have? How large is your classroom, etc. So in fact, we should move more towards a process-based and an outcome-based method of accreditations rather than on the input-based. So to push or to give external pressure for our accreditation agencies to improve, then I try to promote the WFME recognitions, and then our accreditation agencies, with the help of WHO, already applied for WFME recognitions, and they were visited March 2018, and now they have been given 10 years recognitions on the condition that they have to improve in 10 areas. I know these improvements are not easy because it means they have to change some of the government regulation, they have to change some of the law, also they have to influence the national accreditation body that is in fact their supervisor. So this is also a problem. In a sense, I mean, in summary, efforts to improve the quality of medical education is not always smooth and easy. Although we have standards, we have accreditations, instruments, system, and procedures, it is not always followed by a real improvement in the teaching learning process, in the assessment process. Yes, there might be improvement in infrastructure, in equipment, which is easier. You can just buy things. But improvement in the teaching learning process, enhancements in the learning, in the students' learning, a good assessment system, more reliable and valid, etc. These are more difficult, especially also for the students to get more learning, especially for the attitude, professionalism, moral development. You know, these are more difficult rather than all the hardware things. And we have a problem of maldistribution. The government try to provide what we call incentive yeah, for new medical graduates to go to the remote areas, but not many medical graduates are interested to apply. So it means that they prefer to work in the cities rather than in the rural areas. And we still have problem of lack of medical doctors in rural areas. Thank you.
Thank you very much, Titi. And I think you've given us a good example of how complex it can be to shift things, that the creation of standards can have an upstream and downstream effect on influencing curriculum, can be in its best expression used to augment the national policy, etc. And sometimes with the complexity of that, not only in a single nation, but internationally, people can, can in a sense almost give up that accreditation can be helpful. But I think you also emphasized both the complexity of assessing whether the accreditation system is helping or not. You can see that there's a tremendous amount of rich discussion within the boxes, and perhaps can address some of the specific questions about things with Indonesia. But I'd like to have our discussion further looking at other aspects of accreditation and their influence, one of which was alluded to earlier, but that is the issue of do accreditation systems and standardization of accreditation system in the international realm, does that actually promote migration? Does it actually promote the shifting of essential health human resources into areas where they're not needed from areas where they're desperately needed? I'd be interested, Alejandro, in at the start of your career, you're looking out, you have some sense of the accreditation systems and evolving in South America and to some extent around the world. What's your sense of how accreditation systems can, at both the global and the local level, how can they encourage young physicians and enable young physicians to go where they're needed, which is the essence of social accountability?
Yeah, well, I would say it's quite challenging, especially for involving students into the accreditation process. I can tell from my own experience that it is, well, the main idea of involving students is because they will be the ones who will show the world how actually the accreditation process has some impact on the community. So I will say that just accreditation is a baseline for all the activities, all the standards you must comply in order to be accredited, and it will help to everybody to go into the same line of action. So everybody, all the entities, all the universities, all the hospitals will aim for the same focus. But I will have to highlight something John said about the standard declaration, not including rural medicine as well. They not even talk about mental health in the community or even the hospital. So I will say that we cannot only focus into the standards, but also we have to have our own focus, our own scope according to the needs that the community and our students have. I have seen many comments in the chat around how the accreditation can also become an obstacle for students, and it is. Here in Colombia, we are getting to the point where if you come from an accreditation institution, you'll be selected in an easier and faster way to become a doctor and also to find a job. So the idea will be not to only involve students, but also showing them how important it can be for them to comply with the accreditation processes, and also how it's going to impact the community. I think that's something we are not actually quite working on, showing the benefits of it, and also involving people around it. So students actually get into the wave of the accreditation standards, because if you just tell them they have to do something, the students will try to do it. It doesn't mean they actually become part of it.
Excellent, and thank you. And that's the issue of an accreditation system which enables and encourages idealism and service and so on, or one which simply is like the law. You just do this, you do this, you do this. And one of the realities, certainly, of the accreditation systems in North America was always, as I was involved in that and visited the 150 odd schools that were part of the system, is that the voice of the students was considered very, very important by the visitors, because they were kind of seen as the front line of whether the aspirations of the faculty were actually being met. But what you're talking about is also the importance of student involvement in both the creation of the standards and the influence of how the system works. And that's a very helpful perspective. Björg, in terms of moving things forward, you know, part of it is being able to know where we've been and where we're going. And the net, I know, has developed, as you say, at the institutional level, how an institution moves itself forward. I wonder if you could just speculate for not too long, but for a minute, about what about accreditation systems? How do they become more socially accountable? Because that's an initiative that's very active right now, as you know, because you're part of it in developing a global consensus paper on how a social accountability as an idea can be integrated into the accreditation system, and how the accreditation systems would know they're moving in that direction. So I'd love to hear a couple of comments in that level before, and then I want to come back to John in a second.
Look, I think that is a really important question. I think, and there's some of the questions in the chat room have been sort of highlighting that. What is the accreditation mechanism or system about? Is it about making, sort of ticking boxes like Titi mentioned? Is it about, if it is about reform, and I believe maybe it was Jacques Girard mentioned that, is that if it is about progress, if it is about addressing needs, it needs to actually not be sort of one-off standard. It needs to be sort of part of a quality improvement process. And it needs to be guided by a vision for where it's going. It needs to, you know, and therefore rural challenges need to be reflected, and you need to then design, if the accreditation system is guided by a vision of what the education system is supposed to produce. You know, that I think is sort of a step forward. We've been mostly focusing on process and what's in place, and perhaps some very basic outcomes. But I think that sort of the accreditation 2.0 should be really guided by broadly what it is attempting to achieve. And that obviously requires more of a national dialogue with the various, both with education institutions, with health system stakeholders and communities. So I think it will influence who's on that accreditation committee. It should influence how we go about it, so it doesn't become this sort of one-off process where everybody scrambles to make things look good, to, you know, fit a criteria, to become an effort and opportunity to actually reflect. Now, obviously, that's going to be sort of a big challenge in the current political environment. And I think several of the folks in the chat room have talked about these CFMG standards, where there's sort of a push towards standards that have, you know, kind of been set by one country. And that might, like you mentioned also, Bob, foster more migration one way or the other, or, you know, there's also been discussion in the chat about how do you get graduates to go to rural areas if the training is set up in a way that actually, you know, they're trained in hospital settings, they don't have experience, or they come from backgrounds where they're quite privileged themselves. So I think we now have an opportunity to really shape an accreditation process that's much more forward-thinking, much more dynamic and responsive to some extent, accreditation that is socially accountable, and an accreditation mechanism that is dynamic and doesn't sort of get stodgy in terms of standards of way of educating that's been going on for years. So not an answer, but I think more of a reflection that we want others to think about as well. But I think it's a real opportunity for change.
Thank you, Björg, and I think well said. And I think one of the, I hope people have been reading the chat room. People around the world are reading the chat room because some very rich discussions and interchanges there that are relevant to some of the things that were just mentioned. And that's the idea that reluctant conscripts is not necessarily a great way to go. That is to set some kind of standardized goal and demand that each schools in each country tick off the boxes that indicate that they have met those particular goals is very different than having a dialogue. It's very different than saying there is a baseline standard that we must somehow collectively support, and that the accreditation system, rather than being the police that come in once in a while and make sure people are behaving, is an integrated system, integrated with the priorities of the country. So, John, you've been making some useful comments in the book about in the chat room about this idea of finding that sweet spot, and I think there's a sweet spot in accreditation as well as in individual personal choices about where we go. And Alejandro alluded to it too, is creating a draw into better medicine rather than a push into serving in a particular area. And how do you think, John, that the accreditation system can foster that excitement as opposed to trying to sell a hair shirt to somebody that says you should go into rural areas because it's the right thing to do? What are the elements of an accreditation system that can enable that?
Wow, thanks, Bob. Yeah, I mean, I think accreditation systems should be lifelong. Whether you call them accreditation systems afterwards, I don't know, but it's about standards. It is about fostering change and being involved in that process. I've just come back from Bangladesh and spent some time at a rural medical school there, and just fascinating. A lot of altruism amongst the students. You know, they were really keen on wanting to work in rural. So I think we work on the altruism of students. I'm really amazed how well the Australians have done this. And I know it's happening to a certain degree in Canada as well, where actually they turn rural into something exciting. You know, worldwide, rural is seen as second rate, second class. It's something that you don't have to go and do your rural placement in after you've qualified. We're sending untrained graduates to deal with problems that will be worse than they'll ever deal with in the rest of their career. It's no wonder they don't want to go back into rural practice. So I think we need to train people. I think the accreditation process needs to become a lifelong. It's that pipeline or that pathway we're talking about, starting with rural kids at school, you know, finding and helping and promoting young rural children wanting to do medicine, wanting to do community service, wanting to do nursing, working with them, taking them through. So please don't see the accreditation process just that little chunk of medical school. It's something that we need to foster for the whole way. And I do have this real concern, and it's come up in the chat room here, about this compulsory rural service. I think it's more of a problem than it is a benefit.
Thank you very much, John. And you know, time is moving on. And one of the allusions you made, and one thing I'd like to get some last quick rounds about, is this interprofessional. because in fact, one of the challenges of accreditation systems in each of the professions is that they can actually act to separate us from our co-workers. And I'd like to hear maybe a quick thought from someone about interprofessional accreditation and how do we get standards around the way people work together, not just what they do as individuals. And this speaks to what Björg mentioned earlier about a quality improvement philosophy rather than an auditing philosophy.
Now, every profession, they educate their own professions. In some medical schools, they try to incorporate sessions or blocks or modules where they educate together various students from different professions, from different disciplines. But it's limited to that. Although in our accreditation standard and instruments, we already included the parameters on interprofessional educations, but still it is not really what we call it, a substantial change in the culture, in the way of people work. So it's still more just like one-off programs and that's it. So I still have, I'm still thinking of how accreditation can really force or change into the culture of working in silo into more interprofessional. But because the working environment is also influenced by the healthcare system, and it is also influenced by the the way people are what we call appraised, people are assessed how they perform. If interprofessional competencies are not taken into consideration in this regard, then again it is just a lip service in the medical school. And accreditations can be a powerful tool, in fact. But again, changing the accreditation system and methods is not that easy. Thank you.
Titi, thank you. And anything that can be a powerful tool can also be a powerful weapon, as we know, for sameness and so on. But I want to just give each of the four of you 30 seconds each to just say things that we have not yet touched upon or ideas that you want to make sure everybody takes away. There is such a rich discussion in the chat box that I hope everybody, including our many people online, will read that. But are there some things that occur to you that, oh, this is what I want to close with? Alejandro.
Yeah, I would say we will need to think about what they're saying in the chat again. How accreditation is a baseline, but we have to answer the needs of the community and answer the needs of what we actually have in context. And I just wanted to say that most of the students actually want to be working in hospitals because the whole culture around health, it doesn't only include medicine, it includes midwives and also nurses. We have the culture around the world to work in hospitals. It doesn't mean that we are not working in communities, but the reality in every country, it doesn't matter how developed it is, you actually need to strengthen the profile of students going into the rural action.
Thank you. Björg.
So this is not something that hasn't been mentioned, I think, but I do think that it's really important to think about what accreditation is and to make sure that it's actually a continuous quality improvement process and that it be linked to impact and outcome evaluation and that it informs accreditation and vice versa, so that you link it to institutional activities, but make sure that the accreditation process also evolves with what is learned from measuring the outcomes of impact of health professional education.
Thank you very much. John.
Yeah, I just wanted to mention about change, and we live in a very changing world at the moment, and how we kind of manage that change. As a doctor, you know, we tend to think in kind of doctor terms, but the need for health workers is so great. We're 7 million short now. We're going to be 40 million more needed by 2030. WHO, World Bank think there's going to be about 18 million short by then. And we're living in a world that's changing. We're seeing really the predominance now of non-communicable diseases, multimorbidities, a growing elderly population. And so actually we need to change our curricula and our standards and our accreditation to meet those and the skills that were needed. So healthcare will continue without doctors, and I'm sure that I'm going to be shot down for that. But we are incredibly important in that as a member of that team. But our needs are going to be about developing, we're going to become complex problem solvers with people who've got multiple morbidity for managing the elderly. And I think we've got to see that change, Bob, that happens. And the standards and accreditation need to reflect that.
Thank you very much. Titi, can you just take a second, and then I want to bring Nick in to talk about subsequent seminars.
Right. Okay. I'm now more concerned, you know, after working in the accreditations for about 15 years, I'm now more concerned on how to strengthen the internal quality assurance system within the individual institutions, how it is more internally driven, enhancing the internal quality culture rather than externally driven quality improvement, because recommendations from accreditations do not always push or bring changes internally from the institutions. And I'm more concerned apart, you know, to move away from having, you know, global, international or national standard to be more a local standard. Every institution can develop their own standard based on their own vision and mission of the institution in order to meet the health needs of their own populations. So moving towards more regional health system rather than, you know, national health system. Thank you.
Thank you, everyone, and thanks everybody on the line. I think we've achieved our goal of being more than the sum of our parts. The richness of discussion will help us. Nick, do you want to give us a brief nod about Darwin and the Solutions Challenge, and so that we can be inspired to move forward between now and then to take some of these ideas and actually animate them?
Yes, and thanks for all the panelists. Just a couple things. I hope next week the symposium will be on women in health, community approaches, and so we hope you join us for that one. We have a great group of panelists also, and so we hope you join us for that. But in terms of what Bob was saying, all this information that has been contributed today is going to be consolidated, both the video and then the chats, and then drive towards the Solutions Challenge in Darwin, where we'll have a one-day sort of human-centered design process where collectively, as a global community, we'll be able to turn that into policy papers and policy position papers that will be distributed globally so that regional, national, and international people can use that as a tool for their own advocacy towards these particular topics. But thank you, Bob, and thank you for all the panelists.
Well, thank you all again. And the final thing I would ask each of us, those on the line and each of the panelists, is as you leave here today, tonight, this morning, whatever time it is there, I want you to turn to those who are closest to you and thank them for sharing you with us. Because as Titi has said, the local is as important as the global, and it's that connection that needs to be there. So I want everybody to turn to their those closest to them and say, you know, I just spent an hour of your time with these interesting people, and we want to make a better world.